The topic for today is essentially just an overview of the many types of infections that can involve the liver. Some of the most common ones, obviously, we're all familiar with: pyogenic liver abscess, cholangitis, cholecystitis, and then I go into some of the other causes, other etiologies that can involve the liver as well: bacterial, fungal, and parasitic etiologies. So to start, some of the more common ones. So pyogenic liver abscess. We all have managed or at least seen pyogenic liver abscess. Infections that arise through liver abscesses can originate from the hepatic artery, portal vein, or from direct extension from the abdomen or secondary to trauma. Many conditions predispose patients to develop liver abscesses: underlying malignancy, underlying hepatobiliary disease, pancreatic disease, cirrhosis, cardiopulmonary disease, or diabetes. Clearly, it's not a comprehensive list, but some of the conditions that put them at risk. Etiologies. Enterobacteriaceae is the most common culprit organism subgroup that causes infections. Of these, E. coli and Klebsiella are the most common. Of note, there are risk factors for certain organisms. For Klebsiella, for example, patients often do have a higher chance of underlying colon cancer. So patients that I find that as an etiology for, I refer for colonoscopy. And then clearly you can see other organisms as well. Polymicrobial abscesses can be seen, and those can often involve Enterococcus subspecies or viridans group strep. You can also see Staph aureus as a cause of liver abscess, and that often occurs after bacteremia and from hematogenous seeding. Anaerobes can also be seen, and they can likewise be part of a polymicrobial abscess, or they can arise actually more often with patients with underlying hepatobiliary disease or instrumentation of the biliary tree. And clearly you can also have fungal organisms as a cause, most commonly being Candida species. And likewise, hematogenous spread is more likely with Candida. We all know how they present: red or quadrant pain, fever. Labs often reveal a white count and have a predominant elevation in ALK-Phos as opposed to other transaminases such as ALT, AST, and bili. The key is that if you suspect liver abscess, most of the time they present with fever. So blood cultures are key, as you can get a microbiologic diagnosis in up to 50% of cases from blood cultures. Picture on the side is an example of one of the large liver abscesses I saw. This one was secondary to a Bacteroides subspecies and someone with malignancy as an underlying cause. Clearly, if a diagnosis of liver abscess is suspected or there's abnormal transaminases, imaging is necessary. Ultrasound and CT are generally the first go-to. MRI can add you more diagnostic info, such as the structure of the biliary tree, but you don't often necessarily require it. And as we all know, aspirating it is the key for diagnosis, and you can get a microbiologic diagnosis in that fashion. Management does somewhat depend on the size. For smaller abscesses, a simple aspiration for microbiologic diagnosis and to reduce the volume of infection can be helpful. But clearly larger abscesses, especially those larger than 5 centimeters, leaving an indwelling drain can help with resolution. And especially in the case of multiloculated abscesses or those that don't respond to percutaneous drainage and prolonged antibiotics, surgical intervention may be required, but clearly not preferred if can avoid it. In terms of antimicrobial choice, typically, empirically, when someone comes in and you diagnose them with liver abscess, a beta-lactam, beta-lactamase inhibitor combination is preferred. Oftentimes you would use piptazo, or you can use a combination of a 3rd or 4th generation cephalosporin in combination with metronidazole for your anaerobic coverage. Clearly, alternates need to be entertained in those with penicillin allergies, for example, using a carbapenem in those patients. And you also should see if patients are colonized with multi-drug resistant organisms in the past, and you can account for that in your antimicrobial choice. Clearly the definite results, or rather, sorry, the definite management is going to be guided by your culture results if you do get an organism that grows. And typically patients are maintained on antibiotics for at least 4 weeks, especially in the smaller abscesses, but up to 6 weeks and longer in the larger abscesses. And repeat imaging and lab work can guide therapy and duration of therapy. Cholangitis, likewise, something that we're all familiar with. I'll be quick. Clearly refers to infection or inflammation of the bile ducts, and stasis, the most common predisposing factor. Stasis allows for organisms to ascend the bile tree from the proximal intestine. An alternate point of entry is thought to be the lymphatic system or the portal system. And patients, similarly as with liver abscess, present with red upper quadrant pain. The typical finding that we look for is the Charcot triad, but it's not seen in all patients. However, jaundice is appreciated in 50 to 70%. Laboratory analysis, as with the other infectious etiologies, a elevated white blood cell count is typical, and a cholestatic pattern of liver function abnormalities is usual, with elevations in alkaline phosphatase and bilirubin. If an obstruction occurs at the distal bile duct, clearly elevations in amylase and lipase can be seen. Radiology, clearly helpful for diagnosis. Ultrasound is helpful in that it can reveal common bile duct obstruction and visualize gallstones. CT and MRI can be used to add more info, for example, stranding around the bile duct or evaluating the nature of obstruction further. Management, clearly empiric antibiotics, and the choice is similar to liver abscess. Key things to note, once again, reviewing what prior organisms a patient has been infected with, and B, seeing where they developed this infection. If it's inside the context of the hospitalization, accounting for more resistant organisms is reasonable. Management. Medical therapy alone can lead to resolution, but clearly if there is obstruction present, more interventions may need to be undertaken. ERCP is a common approach, lower morbidity than open surgery. A percutaneous approach can be pursued in those that are unstable enough to proceed with ERCP or surgery. But ERCP has the benefit of offering definitive treatment of the underlying obstruction and obtaining tissue to see what causes underlying obstruction. Other entity I'll quickly gloss over is cholecystitis. So condition characterized by inflammation of the gallbladder, not always necessarily infection, but those that are unstable enough to proceed with ERCP or surgery. But ERCP has the benefit of offering definitive treatment of the underlying obstruction and obtaining tissue to see what causes underlying obstruction. Other entity I'll quickly gloss over is cholecystitis. So condition characterized by inflammation of the gallbladder, not always necessarily infection, but typically what I'm going into is acute cholecystitis, typically caused by obstruction at the cystic duct. Obstruction leads to increased intraluminal pressure. This disrupts the blood supply, lymphatic outflow, and then leads to an inflammatory response. And subsequently, that sets you up for an infection in up to 20 to 50% of cases, which is why we use antimicrobials. Likewise, choice is similar to cholangitis and liver abscess. In those with acute cholecystitis, as we all know, they present with pain that radiates the back, can have other GI symptoms, including nausea and vomiting, can have fever and anorexia. And Murphy's sign is the characteristic finding with pain with inspiration when palpating the gallbladder fossa. Workup, as with the other entities, a leukocytosis or predominance of neutrophils is typical. Elevations in bili and alk-phos are not necessarily common unless there is involvement of the common bile duct with an obstruction. And ultrasound is the go-to, which can reveal gallbladder wall thickening, edema, or pericholecystic fluid. CT and MRI can be pursued, but likewise are usually not absolutely necessary. And if a diagnosis can't be established by ultrasound, if a HIDA scan is available, it can add more info and help make the diagnosis. So, as we all know, with HIDA scans, a tracer is injected intravenously, incorporates into the hepatocytes, it's secreted in the bile, and if the cystic duct isn't patent, you will not visualize the gallbladder. Management, likewise, empiric antibiotics. I mentioned that the coverage is pretty similar. Once a patient cools down, surgery ultimately should be pursued. But some indications where you have to pursue surgery more urgently is when there's suspected gangrene or perforation. And in those that do respond to medical therapy alone, however, cholecystectomy can be delayed. And those that cannot safely pursue surgery but need some form of drainage, a percutaneous or ERCP approach can be done. So now into the more interesting stuff. So etiologies of other types of hepatic and biliary infections. So bacterial, went into this a little bit. Clearly, aerobic gram-negative bacilli, E. coli and Klebsiella are more common. Gram-positive organisms definitely can cause disease as well. But some of the more notable or interesting etiologies would be tuberculosis, typhoid fever, lepto, Brucella, and Q fever. So first one I'll get into is TB. So as we all know, tuberculosis is initially develops in the host when the causative organism, Mycobacterium tuberculosis, is inhaled in aerosol droplets. And hepatic and biliary involvement results when there is dissemination in the context of primary infection, or if you have reactivation of latent disease in the patient. For example, when they undergo immunosuppressive therapy. And there have been some forms of hepatic involvement classifications suggested. So miliary TB or miliary presentation is most common where there is diffuse hepatic involvement. However, there is granulomatous disease described where you can develop caseating granulomas in the liver and you can have resulting hepatitis and fever. But there's a third entity, localized hepatic TB, where you can have bile duct involvement and you can form tuberculous abscesses or tuberculomas in the liver, more focal abnormalities. Presentation. It fits in the general picture of someone with tuberculosis. Patients can present with fever and unintentional weight loss, but clearly with involvement in other organs, hepatomegaly, splenomegaly, and subsequently jaundice. Elevations in transaminases are typically modest or moderate. And then diagnosis. So imaging, depending on the type of dissemination to the liver, can show either solitary or multiple lesions. And if you biopsy these focal lesions, you can sometimes see the actual acid-fast organism, but it's relatively infrequent, and isolating it by culture is also sometimes difficult. Something that we have been using more recently is on these types of specimens, adding a Mycobacterium tuberculosis PCR. Investigational, not technically approved in a lot of these instances, but can help you with the diagnosis. Clearly, if tuberculosis is suspected, obtaining an IGRA, a interferon gamma release assay, for example, in our institution, a quantiferon gold, is reasonable, or if that's not available, obtaining a PPD. Of note, it clearly does not distinguish between active disease and just prior exposure to the organism. And it can be falsely negative in the context of disseminated disease due to inadequate immune response. Something to note, though, is you don't always have to pursue biopsy of hepatic lesions. If you have a positive sputum with Mycobacterium tuberculosis and otherwise a clinical picture that fits, you can make a presumptive diagnosis. Treatment, it's somewhat similar to isolated pulmonary TB. It generally involves 4 active drugs. Clearly have to take into account local resistance rates for the antituberculous agents. But the go-to, unless resistance is suspected, is still rifampin isoniazid in combo with B6 to avoid neuropathy, pyrazinamide, and ethambutol. Clearly, if MTB is actually isolated, sending it out for susceptibility testing is important to make sure that your therapy will work. The thing to note is that if the patient has more disseminated disease and, for example, central nervous system involvement, duration can be extended from the traditional 6 months to 9 to 12 months of therapy. And something to note is that generally after the initial intense phase of therapy with 4 drugs. Typically, you de-escalate down to 2 drugs, usually rifampin and isoniazid. So other etiology, typhoid fever, something that can cause liver involvement. So typhoid fever caused by Salmonella, Enterica serotype typhi, and infection in the United States is typically due to patients returning from endemic areas, including sub-Saharan Africa, South Asia, and South America, clearly not limited to these locations, however. And infection can occur after contaminated water or food is consumed. And once ingested, the organism passes through the intestinal epithelium and proliferates in the submucosa. Incubation is somewhat variable, but typically 1 to 2 weeks. And it can be dependent on the inoculum of bacteria that one ingests, and it does depend on host risk factors such as immunocompromised state, where it can be more rapid. And the organism typically disseminates through the lymphatic system and subsequently through the bloodstream. Liver and spleen can be involved following dissemination. And on imaging of the liver or on pathology, you can see typhoid nodules. And histologically, these nodules do tend to have a monocytic infiltrate with foci of parenchymal necrosis. The gallbladder can also be involved with similar monocytic infiltrates visualized on biopsy. And rarely the gallbladder can actually perforate in the context of these infections. The most common symptom is fever. And GI involvement, interestingly, can present with either constipation or with diarrhea. Another notable association with typhoid infection is a relative bradycardia or a pulse temperature dissociation. And patients can also present with, as we have heard, rose spots, which are blanching salmon-colored macules that often appear on the trunk or the abdomen. And depending on involvement and extent of disease, you can appreciate hepatosplenomegaly. Diagnosis can reveal either leukocytosis or leukopenia. You can see anemia, and most notably, elevated serum transaminases are observed and can be 2 to 3 times the upper limit of normal. Diagnosis, especially if you can't isolate by culture, often is on a clinical basis, especially if you're in an endemic area. Blood culture is the most common definitive method of diagnosis, however. One of the more useful tests that we have recently is PCR from the stool, and this can be very sensitive. Stool culture can clearly also be obtained and is helpful if you don't isolate the organism from blood, as you can perform susceptibility testing on a stool specimen. And classically, a Weidel test was used, which detects agglutinating antibodies against the O and H antigens. But the sensitivity and specificity is low, so at least in the United States, it's not commonly utilized anymore. The other thing to note is even after treatment of acute infection with typhoid, assessing for chronic carriage is important, and at least 3 stool cultures should be obtained separated by several days or weeks apart, just to exclude chronic carriage in the patient. Treatment, it's location, location, location. There are high rates of resistance forming to fluoroquinolones, Bactrim, and 3rd-generation cephalosporins, especially in Asia, India, and Pakistan. And in infection outside of these areas, you can treat with a fluoroquinolone for mild disease or with a 3rd-generation cephalosporin such as ceftriaxone for severe disease. However, if a patient is coming from areas with high rates of resistance, zithromycin is the preferred alternate for mild disease, and a carbapenem is used empirically for severe disease until susceptibility testing is performed. But clearly, therapy should be guided by culture and sensitivity data in typhoid fever. So another interesting entity that can involve the liver is Brucella. So human infections are typically caused by 4 species, including Melitensis, Suis, Abortus, and Canis. The main animal hosts are sheep and goats for Melitensis, pigs for B. suis, dogs for B. canis, and cows for B. abortus. And most human infection described is caused by Brucella melitensis. Infection can occur through several means, but most commonly occurs by consumption of infected or unpasteurized animal products such as milk. But infection can occur, for example, in veterinarians when there's contact of open skin wounds or mucous membranes with infected animal tissue such as placenta or animal body fluids such as urine, blood, or milk. But you can also develop infection by inhalation of aerosolized animal products, for example, after a veterinarian assisting with a delivery. So in the host, once the organism is ingested, it migrates to local lymph nodes inside neutrophils and macrophages. It multiplies intracellularly and invades neighboring cells, lymph nodes, and then can spread to distal sites such as the spleen, liver, and bone marrow. And the incubation period is highly variable, but it can take several months to develop overt symptoms. And as I mentioned, illness presentation likewise is highly variable. It can either be an acute febrile illness or you can present with chronic symptoms. And a constellation of symptoms have been described, including fever, arthralgia, fatigue, anorexia, myalgias, night sweats, lymphadenopathy, and back pain. But it is somewhat dependent on where you have involvement with the organism. Of note, hepatomegaly can be appreciated in up to half of patients. Splenomegaly can also at times be seen. And when the liver is involved, patients can present with a hepatitis type presentation, typically a granulomatous hepatitis. And of note, Brucella melitensis can have a diffuse or granulomatous presentation in the liver, while Brucella abortus does appear to be predominantly granulomatous. And other things of note is that liver abscesses have been described with Brucella suis, and untreated infection due to Brucella can result in hepatic decompensation and cirrhosis. So the diagnosis needs to be arrived at and the underlying infection treated as soon as possible. So lab abnormalities can likewise have a number of findings in these patients, including anemia, thrombocytopenia, and you can either have leukocytosis or leukopenia when patients have brucellosis. And increased serum transaminases are seen in up to 25%, especially if there's diffuse involvement of the liver. Jaundice does appear to be a somewhat more uncommon finding, and diagnosis can be reached at through several means. A serum agglutination assay is a common diagnostic tool, and a titer of greater than 1 to 160 is considered diagnostic, but titers can remain high after treatment, and unfortunately aren't always the best guide as to response to therapy. Clearly, positive cultures are the best method of diagnosis if they are ultimately positive, and blood and bone marrow specimens appear to have the highest yield. Blood culture yield is variable, but in studies has been described ranging from 15 to 75%. And molecular testing has been described PCR from blood or from tissue specimens, and PCR clearly can develop before serum antibodies develop. Treatment, it's usually with doxycycline in combination with either rifampin or intravenous gent. Rifampin is typically maintained for the full 6-week course, and gentamicin is used for the first 2 weeks of therapy in conjunction with doxycycline. Another interesting entity is Q fever, which is caused by Coxiella burnetii. Coxiella burnetii is an intracellular gram-negative coccobacillus. Animal reservoirs are cattle, goats, and sheep. And in animal reservoirs, the organism is found in urine, feces, milk, and placental tissue. Infections have been described worldwide and generally is following inhalation of infectious particles. The organism multiplies in the lungs and then can disseminate through the bloodstream. Incubation period is highly variable from what I've seen and ranges from 1 to 39 days with an average of approximately 20 days. As the organism initially enters through the lungs, pneumonia is typically the initial finding, and then subsequent manifestations depend on which site is involved, but can involve acute endocarditis, encephalitis, aseptic meningitis, osteo, or hepatitis. And symptoms, like I said, depend on the organ system involved. And the common symptom, irrespective of which organ system involved, is fever. Hepatitis is frequently seen, and the characteristic finding, which you may have learned in medical school, is a donut granuloma. And these are typically seen when, because there's a dense fibrin ring surrounded by a surrounding a central lipid vacuole. And diagnosis. In terms of basic laboratory abnormalities, likewise, the findings are variable, but it can include an elevated white count, thrombocytopenia, or even an elevated platelet count. And elevated transaminases occur in many patients and can be 2 to 3 times normal. Serum bilirubin is usually normal, but can sometimes be elevated. And diagnosis is usually established by serology with an immunofluorescence assay. You can't culture out this organism unless you have a level 3 biosafety lab. So typically that's not the method of diagnosis. But PCR has been employed on blood and tissue samples to facilitate diagnosis. Treatment, it depends on whether a patient has acute disease or chronic illness. Acute infection, for example, just pulmonary or pneumonia, is treated with 14 days of doxycycline. And then chronic infection, such as endocarditis, is treated with doxycycline in combination with hydroxychloroquine, and the minimum duration there is 18 months. So moving on to fungal infections. So not all fungi, or rather few fungi, have a direct predilection for the liver, but often involve the liver due to dissemination. Candida species are the most common cause of liver infections, and they can either be part of a, for example, microbial liver abscess or a polymicrobial one. And frequently, you can have cholangitis or cholecystitis with Candida species as a cause for superinfection. And the most common entity, however, is hepatosplenic candidiasis. And this entity occurs in patients receiving chemotherapy for cancer. Chemotherapy induces damage to the intestinal mucosa, and this is thought to lead to candidemia, where subsequently the liver and spleen are seeded, especially in patients that are not being prophylaxed with an azole or an echinocandin. And patients then can present when the neutrophil counts recover and after prolonged periods of neutropenia. And the most characteristic symptom is prolonged fever, despite broad spectrum antibiotics. Patients clearly can also have abdominal pain, hepatomegaly, splenomegaly, or skin lesions as well. And the most notable lab finding is an elevated alk phos, which can be 3 to 5 times the upper limit of normal. Transaminases can actually be normal or just minimally elevated. Typically, CT or MRI imaging is key and can reveal a characteristic bull's eye or targetoid lesion. Generally, either you arrive at the diagnosis with clinical suspicion or following drainage. Treatment typically involves either an azole, such as fluconazole, or an echinocandin. But clearly, if you have an organism on a blood culture or on an aspirate, you would go off the culture data to guide your therapy. So another infection which can disseminate to the liver in the context of disseminated disease is Cryptococcus. So I'm primarily going to go into Cryptococcus neoformans, but cryptococcosis is caused by either Crypt neoformans or Crypt gattii. Infection due to C. neoformans is most common, and this has a worldwide distribution. C. gattii is primarily endemic to regions of Australia, Africa. Some cases, however, have been described in British Columbia and the Pacific Northwest of the US. C. neoformans is typically found in the soil, contaminated with pigeon or chicken excrement. And infection occurs when the smaller yeast forms called basidiophores are inhaled by the host. And depending on the burden of exposure, the host immune system, an initial infection can either be asymptomatic or symptomatic. And it's most commonly described in the immunocompromised host, for example, in patients with advanced HIV, AIDS, stem cell and solid organ transplant recipients, patients with hematologic malignancies, or those on high-dose corticosteroids, for example, more than 20 milligrams of prednisone daily. Following exposure, patients can develop a number of findings in the lungs initially, and infiltrates have been described as either lobar or interstitial. Patients can also have pulmonary nodules. They can develop cavities in the lung. Actual masses have been described. Just adenopathy alone has been described, or a miliary pattern can be seen as well. And especially in the immunocompromised host, infection can disseminate to other sites in the body. Clearly, the most characterized and most frequently described is the central nervous system, which results in subsequent meningitis. But you can also see skin dissemination with these umbilicated papules rising in these patients. Now, if the liver is involved in the setting of disseminated disease, biopsy can sometimes show inflammatory changes with apoptotic hepatocytes and or with granulomatous changes. Cryptococcal organisms have been described in the hepatic sinusoids or near the portal areas in these specimens. And if nodules are evident in the liver, biopsies of these can reveal granulomatous changes or central necrotic tissue with peripheral histiocytic aggregates. Diagnosis. So in terms of lab abnormalities, when there is hepatic involvement, typically there is a cholestatic jaundice type presentation, but you can also have elevated AST and ALT with a predominant elevation in alk phos. Diagnosis, we typically use a antigen assay to establish diagnosis from either serum or cerebrospinal fluid, but you can also isolate Cryptococcus on blood culture or spinal fluid specimens or from biopsy specimens. And biopsy nodules, likewise, as I mentioned, can yield organisms. Treatment does depend on severity of disease and site of involvement. So with mild pulmonary disease, you can get away with fluconazole alone as therapy for 6 to 12 months. But in those with severe disease or with meningitis as a presentation, typically amphotericin flucytosine is used initially for a minimum of 2 weeks until the cerebrospinal fluid cultures are negative. So repeat LPs in these patients are important until you clear the CSF. Following the initial intensive phase, you follow the consolidation maintenance therapy with fluconazole for 6 to 12 months. So another fungus that can disseminate the liver is Histoplasma. So Histoplasma is a soil-based dimorphic fungus, and it proliferates best in soil contaminated with bird or bat droppings. And cases of histo have been described worldwide. In the United States, at least, the incidence is highest in the Ohio and Mississippi River valleys. The organism has a mycelial and yeast phase, and the infectious phase is the mycelial form, which contains microconidia. These are inhaled by the host and settle in the alveoli, and at temperatures greater than 37 degrees Celsius, for example, inside the host, microconidia transform into the yeast form, which are ingested by macrophages. The macrophages are unable to kill the fungi, and the macrophages help disseminate the infection. So initially, as the lungs are initial nidus of entry, you can develop a bronchopneumonia, and then subsequently, organism can disseminate to local lymph nodes. From there, hematogenous seeding can occur, and sites with high quantities of macrophages, for example, the liver and spleen, are often involved. Systemic dissemination occurs most commonly in the immunocompromised host. As with Cryptococcus, it's commonly HIV/AIDS patients, those that are organ transplant or stem cell transplant recipients, or those that have hematologic malignancies undergoing chemotherapy. Incidence for dissemination is 1 in about 2,000 cases. So liver, as I mentioned, is a commonly involved site, and most commonly hepatomegaly and diffuse infiltration is described. And focal lesions are seen in a minority of cases, and these lesions have been described as small nodular, less than 1 centimeter lesions, and on biopsy you can see granulomatous changes, and sometimes histoplasma organisms can be seen with methenamine silver stains, and otherwise there are other methods of diagnosis aside for visualizing the organism, which involves checking for a urine or blood antigen test. An antibody test can also be useful and be used to see if someone has been previously exposed, and sometimes can lead you to a suggestive diagnosis. PCR has been employed at times as well from either target biopsy sites or from serum. But in terms of lab abnormalities, those with disseminated infection typically have leukopenia, anemia, and thrombocytopenia. And in hepatic involvement, elevated ALT and alk phos are seen in a very high proportion of patients with disseminated histoplasmosis. You can also occasionally isolate it on culture from a respiratory source. So treatment, similarly to crypto, the treatment is guided by severity of disease. Severe disease is treated with amphotericin initially, and then followed by a azole antifungal. Most commonly, itraconazole is utilized. Posaconazole and voriconazole can be alternate options, but fluconazole does appear to have less favorable activity against histoplasmosis. Another dimorphic fungus that can cause infection in the liver is coccidiomycosis. So coccidiomycosis is caused by two subspecies, Coccidioides immitis and Coccidioides posidacei. And Coccidioides species are endemic to the southwest United States, parts of Mexico and South America. Likewise, with histoplasmosis, it grows in a mycelial form in the soil and in microbiologic culture. And the mycelial form has barrel-shaped arthroponidia that develop and tend to aerosolize. These are then inhaled by the host, and this is where it remodels into a sphereole, remodels in the lungs. These spherules mature and ultimately rupture and release endospores, and these propagate either locally in the lungs or disseminate in the host. So presentation, typically, given the initial portal of entry, respiratory symptoms develop, and these can occur 7 to 21 days following exposure. There's a number of interesting associations. Erythema nodosum is associated with coccidiomycosis, and erythema multiforme skin lesions as well. Imaging findings are highly variable depending on inoculum of the organism and host immune factors. But imaging findings can either reveal pulmonary infiltrates, effusions, adenopathy. You can also see nodules, cavities, or fibrocavitary lesions. And the most common symptom is fever. If you have hepatic involvement, you can also develop abdominal pain and jaundice. But clearly, given the initial nidus of entry, respiratory symptoms are typical. Patients generally do have a leukocytosis, but it's an eosinophilic predominant, and that can be the hint to get you the diagnosis, especially if there's travel to that area or you're dealing with the organism in that area. And with respect to the LFT abnormalities, elevations in alk phos and bilirubin are can be suggestive or typical. So likewise, coccidiomycosis doesn't necessarily have a predilection for the liver, but it involves the liver in the setting of disseminated disease. It occurs in about 0.5% of all infections, and likewise is more common in those with hematologic malignancies, HIV/AIDS, those on TNF inhibitors, or on high dose of prednisone greater than 20 milligrams. And the most common manifestation when you do have hepatic involvement is granulomatous hepatitis. So if a focal granuloma is seen and biopsied, this can reveal granulomatous changes on histology and eosinophilic infiltrate, and you can actually see the spherules of coccidiomycosis on that specimen. And there have also been some cases described that I've seen of actual hepatic abscess with this organism. So diagnosis. Typically, coccidiomycosis is diagnosed by an enzyme-linked immunoassay for IgM and IgG antibodies. If that's positive, it's subsequently followed up by an immunodiffusion antibody test, which is used to confirm the diagnosis. The organism can grow in blood, sputum, and body fluids. However, if you suspect the organism as a cause, please notify your lab, as it is infectious in the lab setting and should be culture should be maintained under the hood. This also applies to Brucella that I described previously. So biopsies can reveal the organism on histologic staining as well, as I mentioned previously. So treatment. Coccidiomycosis is treated with fluconazole or itraconazole. As with the other fungal infections, your choice of therapy is guided by severity of infection. So severe disease is treated with amphotericin, and length of therapy is likewise dependent on the severity of infection, how immunocompromised the host is, but treatment can be up to 12 months. And of note, those with meningitis are often placed on lifelong suppression due to a high relapse rate of infection. Now, moving on to parasitic infections. So, most common one, malaria. So, malaria is caused by infection due to protozoan parasites in the genus Plasmodium. The most common infection is caused by P. falciparum, then this is followed by a Plasmodium vivax. So, as we know, malaria is transmitted by the bite of an infected Anopheles mosquito. Sporozoites are injected into the bloodstream, they circulate, invade hepatocytes, and inside hepatocytes, the sporozoites mature into tissue schizons, which subsequently release merozoites into the blood. These invade human erythrocytes and multiply through sexual reproduction. The key note is that P. vivax and P. ovale are unique because they have hypnozoites and can be in a dormant phase after infection for months from initial inoculum. And patients can be asymptomatic and then develop symptoms when those tissue schizons, when the hypnozoites mature into tissue schizons. Incubation is highly variable and likewise depends on the species. Fever is the most common symptom. A number of other symptoms have been described, including headache, diaphoresis, malaise, arthralgias, abdominal pain, diarrhea, etc. Physical exam findings are often secondary to anemia, especially when there is more severe infection, and this can include pallor, conjunctival pallor, for example. And depending on the extent or severity of infection, you can actually have palpable hepatosplenomegaly. So laboratory analysis most often reveals anemia, and as a result of the hemolysis, you can have elevated LDH and unconjugated bili. You can also see a decrease in haptoglobin. And in cases, especially in severe falciparum infection, elevations in serum transaminases can be quite profound, and evidence of other organ dysfunctions such as elevated BUN creatinine can be seen. Diagnosis. Classically, you use thin and thick smears. The benefit of this is that you can actually identify the specific species causing infection. For example, with falciparum, you can see banana-shaped gametocytes. Although in resource-depleted settings, you can use rapid diagnostic tests. And another methodology employed is blood PCR. And depending on the PCR assay, you can actually also differentiate species as well. And PCR is more sensitive than the thick and thin smear. Treatment, it depends on the subspecies that causes infection. It's also highly dependent on your chloroquine resistance rate in the area that the patient comes from. So some alternates include mefloquine, malarone, atopic proguanil, and for more severe disease, you can use artesunate, artemether, or quinine in combination with doxy. But uniquely with ovale and vivax, given the hypnozoites, patients are generally treated with treatments generally followed by primaquine for 14 days. An alternate is tenefovir. But a note is that you should check G6PD if you're going to use either of these agents. Moving on to the next entity, Amibiasis. So Amibiasis refers to infection with protozoan parasite in the genus Entamoeba, and uncommon in the United States, but common in other in areas outside of the United States. Infection occurs when you ingest cysts in food or water containing fecal matter. These cysts migrate to the lumen of the intestine, where excistation occurs. Trophozoites migrate to the colon and adhere to the colonic epithelium, and then the organism multiplies by binary fission, ultimately encysts and are released in the stool. So most infections are asymptomatic, but up to 10% of patients can develop symptomatic colitis. Spread to the liver is rare and occurs in less than 1% of cases. The presentation of a liver abscess from an amoeba is similar to a pyogenic liver abscess. For example, you can have fevers and right upper quadrant pain. And in patients that actually have the liver abscess, as initial INEDSYS colonic disease, you can have either preceding GI symptoms or current GI symptoms. And symptoms due to liver abscess generally occur less than 2 weeks after exposure, but in some instances have been described months or even years later. So hepatic involvement, liver infection occurs when the organism migrates through the portal vein. The organism causes apoptosis of hepatocytes and neutrophils, and this results in a very characteristic large non-purulent abscess characteristic of an anchovy paste. And men and women appear to have similar rates of infection, but men are 10 times more likely to have invasive disease, including liver abscess. So diagnosis. Clearly, if a patient has pain, fever, and abnormal transaminases or bili, imaging is necessary. And imaging with ultrasound or CT can reveal a space-occupying lesion, commonly a single large abscess, but multiple abscesses have been described as well. Abscesses are a predilection for the right lobe, but can be present in other sites. And if aspiration is pursued, trophozoites are only seen in about 25% of cases. PCR has been employed on these samples in instances, but generally is research only or a send-out test, especially here in the States. So if diagnosis suspected, serology is useful, but the key here is that it will only confirm, prior infection. It can be persistent afterwards. So other testing methodologies include checking a PCR from the stool. This is highly sensitive for amoebic colitis. Thing to remember is that you might not have active colitis by the time you develop a liver abscess, so you might have a negative PCR from the stool. So treatment. Oftentimes you can use medical therapy alone with a nitroimidazole, such as metronidazole or tinidazole. Those treated with nitroimidazoles often don't clear intestinal colonization and are primomycin. And then if there is a very large abscess, or if the diagnosis isn't clear, or if you suspect superinfection of the amoebic abscess with bacteria, an aspiration can be pursued. Another entity is echinococcosis. So echinococcus occurs due to the Echinococcus species of cestodes. Echinococcus granulosus causes hydatid or unilocular disease, and then Echinococcus multilocularis results in alveolar disease predominantly. Humans serve as a coincidental intermediate host, canines the definitive host, and then sheep, goats, and horses are the usual intermediate hosts. Disease occurs after you ingest a parasite egg in contaminated food or water. Once in the intestinal tract, the eggs hatch, form an oncosphere, and then this penetrates the mucosa and enters circulation. The oncosphere then insists in host viscera, which with Echinococcus granulosus occurs most often in the liver in 50 to 70%, but can also occur in the lung, brain, bone, and heart. Presentation. Oftentimes cysts, you can be asymptomatic with infection, but symptoms develop due to mass effect of the cysts. So for example, in the liver, the cyst can compress the biliary tree and result in cholestasis, or they could compress the vasculature and lead to venous obstruction, portal hypertension, or even Budd-Chiari syndrome. Another issue with these cysts is that they can either rupture or leak and release and cause allergic reaction due to release of echinococcal antigens. And the most dreaded outcome is an anaphylactic reaction with fever and hypotension. So cyst rupture into the peritoneum can result in peritonitis, and rupture to the diaphragm can lead to pulmonary hydatidosis or formation of a bronchial fistula. And the other thing to remember is that cysts that either leak or rupture can then become superinfected with bacteria. So diagnosis by imaging. And this is actually a picture of a patient that we saw in Northwell that had very extensive disease. This is an MRI abdomen demonstrating multiple cysts with the left lobe lesion demonstrating what's called a double line sign. So imaging findings do vary based on the stage or actual age of the cysts. And cysts can be either unilocular with a double line sign, as on the right, multiseptated with rosette-like or honeycomb-like appearance. You can have detached membranes of the water lily sign. You can have internal formation of daughter cysts, or you can have heterogeneous contents, or even a solid lesion with a calcified wall. And the key for making the diagnosis is determining epidemiologic risk. Diagnosis can be supported by a enzyme-linked immunosorbent assay or Western blot, but can actually be falsely negative at times. So treatment is variable, and it does depend on the stage of the cysts on radiography. So that was the recommendation by a WHO informal working group. Multiple approaches are taken to therapy, and they, once again, depend on the stage of the cysts. They can involve percutaneous therapy, laparoscopy, or even open surgical resection. And especially those with multiple cysts, sometimes a combination of approaches is necessary. If taking a percutaneous approach, typically an installation of a cysticidal agent is done after removing a fraction of the cyst fluid in an effort to prevent rupture of the cyst. So cysticidal agents include either hypertonic saline, cetrimide, or 70 to 95% ethanol. And another key is that prior to pursuing a percutaneous or surgical approach, oftentimes an antihelminthic agent such as albendazole or mebendazole is used perioperatively in an effort to decrease risk of dissemination of daughter cysts and prevent allergic reactions. And in those with inoperable cysts, or those that are very small or relatively young, sometimes medical therapy alone with mebendazole or bendazole can be sufficient alone to lead to cure. And last infection I'll go into is schistosomiasis. So there are 5 main species that cause hepatosplenic involvement. These include Mansonii, Japonicum, Mekongii, Intercalatum, and Guinensis. Schistosoma hematobium is a common cause of human infection, but primarily causes genitourinary complications. So in terms of locations, Mansonii is commonly found in South America, Caribbean, Africa, and Middle East. Japonica is described in Indonesia, China, and the Philippines. Mekongii is endemic to Cambodia and Laos. Intercalatum and Guinensis is seen in West and Central Africa. So life cycle, it is complicated. It begins when the eggs are released in the host venules and ultimately excreted in the urine or feces. The eggs hatch in fresh water and release a ciliated larval stage called a miracidium. The miracidium seeks out an intermediate snail host and reproduces asexually in the intermediate host. Following reproduction in the snail host, a motile cercariae emerge. The cercariae encounter human skin, penetrate it, and then transform to schistosomula. Schistosomula subsequently migrate to the lungs and liver, and in approximately 6 weeks mature into adult worms. The adult worms then migrate through the venous system to their various end organ sites. So there's also entities described as acute schistosomiasis and then chronic schistosomiasis. Acute is also known as Katayama fever, and Katayama fever can occur in, most commonly occurs in those previously uninfected and develops 2 to 12 weeks following exposure. And typically presentation is with acute onset of chills or fever. You can also have a number of constellation of other findings, including abdominal pain, diarrhea, headache, and arthralgias. But you can even have respiratory symptoms, including cough, dyspnea, and chest pain. And on physical exam, lymphadenopathy is typical, and hepatosplenomegaly can be appreciated. And eosinophilia is very common in these patients. So in chronic infection, or rather with chronic infection, you can either have intestinal or hepatosplenic disease. So infections with Mansonii, Japonicum, and Mekongii, those are most common to have a prominent hepatic disease picture. And with Intercalatum and Guinensis, there's more typically intestinal involvement alone. But one of the early signs of hepatic involvement is the development of hepatomegaly due to granuloma formation around the eggs, which deposit in the portal vein. As a result of the chronic inflammation, about 5 to 10% of young and middle-aged adults actually develop something described as a Simmer's pipestem fibrosis or a periportal fibrosis. Other consequences of chronic infection are splenomegaly, portal hypertension, portal cable shunting, and in the worst case, unfortunately, decompensated hepatic disease. And in chronic disease, liver enzymes are often not particularly elevated, and the presence of eosinophilia can depend on the burden and duration of infection. So diagnosis. Microscopy is one of the gold standards, and microscopy of stool, that is. And in those with hematobium infection, urine microscopy actually pursued to visualize eggs. Enzyme-linked immunoassays, or ELISAs, have been developed for the various species. In the United States, generally, it would be a more research test, but these tests are more commonly available in endemic settings. The key note is that false negative assays can be seen in acute infection, as they are only positive 6 to 12 weeks after exposure. But there are PCR assays utilized to detect DNA in urine, stool, and serum. And treatment, generally it's praziquantel. Dosage does vary, but it is limited to 1 day of treatment, and dosage does vary based on species. So that's it. And I'm available for any questions.